to put out the shunt and do your third ventriculostomy. If you have a CSF infection with a protein more than 300, so do not do endoscopic third ventriculostomy. If you have a protein less than 300, go for third ventriculostomy.
On time consuming, I'm asking about how many ventriculostomy can you proceed in morning?
You need a counter. Actually, you are talking about the learning curve. The starting endoscopic third ventriculostomy, when I first started in 1995, I was doing the procedure in 1 hour 30 minutes. We are doing a straightforward endoscopic third ventriculostomy now in 16 to 17 minutes. So there is a learning curve in endoscopic procedures. Maybe at the start you will, let's take the average and you will do it in 1 hour. So if you have 4 hours operating time in the morning, you can do 4 ATVs. When you diagnose infection, you have to take a sample of CSF to see the color. Okay, it's not obvious, so the proteins will not be that high. So you go for third ventriculostomy. Try third ventriculostomy.
Even you found there is a clean, not clean CSF by your inspection, you see
The non-clear CSF is an obstacle doing this surgery. But you have to wait and wash for 5 or 10 minutes to get rid of this debris and put a clean media you can operate through.
I'm just going to take the chance that I'm chairing this session to ask 3 questions probably. Because nobody is raising his hand now. My first question, now putting in consideration that we might counter such problems like iliacus membrane. What's the pre-operative investigation that you do for such patients? Do you just resort to CT scan or do you need to do always MRI before doing the procedure? The next question, how often do you see problems like subdural hematoma after doing the procedure? And thirdly, we know that is with ventriculostomy, that is the best is the obstructive type of hydrocephalus. And especially says if somebody is having a tumor, the fourth ventricle, and there must be 2 choices. I can take that patient to the theater and do ventricular tapping just before proceeding with the resection of the tumor. So when do you choose to do ventriculostomy for such patient? What type of patient do you choose actually? Thank you.
About the first question, actually we do MRI in every patient with hydrocephalus to avoid many things, the anomalies and the pre-poncitine cistern assessment and the foramen of Monroe assessment. And this is a routine study in performing endoscopic third ventriculostomy. And about the second question, the subdural hematomas. The subdural hematomas is collecting if you have injury of a cortical vessel and is still leaking inside this space. But if you have a clean field and you coagulate the cortex well and the pia well before introducing your ventriculoscope, this will make no subdural hematomas. Yeah. Actually, no sudden release. You have a controlled release of CSF. You have a controlled release because you're using an obturator which is fenestrated. You can control the CSF going out of the ventricle, not suddenly decompress the ventricle. Yes, yes, yes.
Is
And
there any role for ultrasonography to diagnose the thickness of the mucous membrane intraoperatively?
actually, the introduction of ultrasound probe is quite new in neuroendoscopy. The probes is still bulky and not that efficient to resize or sizing the thickness of the liquid membrane. Because the size of the probe and the frequency they use in the ultrasound is still manufacturing.
If it's there, can you use it?
The ultrasound,
Yes.
if it's there, I'm using. I'm going to use it.
Yeah. Is it helpful?
To assess the liquid membrane or to no, I don't think it's of benefit to assess the liquid membrane. I think even the MRI is deceiving. You may go with a MRI with no obstruction, and you go inside there, and you found the liquid membrane obstructing the floor. Yeah, this is an intraoperative finding. Yeah.
Okay, thank you again, Dr. Darrag, and thank you for your contribution and discussions. Well, I just came to know that the next presentation is going to be incorporated in the practical session. So we'll be having more time to do the practical session, and at the same time we'll be discussing about the instrumentation. Just before we move to the other room, probably Dr. Darrag is going to give some announcement. Well, later,
الرحمن الرحيم. بالخصوص البراكتيكال تم التقسيم ل5 مجموعات. هتبدا المجموعات من 1 ل4، كل مجموعه فيها 6 زملاء، والمجموعه الخامسه بتبدا بعد ما يقل العدد شويه. العشاء هيكون الساعه 9:30 في صاله الاسكل على شارع النيل. وبكره العمليات الساعه 8 صباحا في مستشفى الشعب. هيكون الناس في قاعه السيمينارات لحد الساعه 11:30. والليكشرز بكره هتكون في نفس المركز هنا. العمليات هي هتكون قاعه السيمينارات في مستشفى الشعب لغايه الساعه 11:30 تقريبا او 12. والمحاضرات بتبدا هنا من 12 لغايه 3، وبعدك حيكون في الختام وتوزيع الشهادات. شكرا. العمليات حتكون في السيمينارات، قاعة السيمينارات حيكون في بروجيكشن، يعني العادة حيكون في السيدة حيكون عدد محدود يعني. ان شاء الله ان شاء الله. ايوه ايوه.
So you are invited now to move to the other room. Yes, those who want to attend.
المجموعة الخامسة اللي هي حتنتظر شوية هي